to our first. Thank you, Memo. Uh, Hello, everyone. Happy Friday, and welcome to our first CalAIM Provider Learning Circle of 2026. My name is Berenice Herrera Lopez, and I'm the Operations and Programs Director at the Health Improvement Partnership. And we serve as the PATH Collaborative Facilitator for the County of Santa Cruz. It is our pleasure to have for you today a session focused on ethical decision making and best practices in enhanced care management and how these considerations show up in the day-to-day work of supporting members through ECM. So with that, if we can advance to the next slide, Memo. Just wanted to introduce you all to folks on the call with me today. So we have Memo de la Riva, our operations coordinator, supporting us with Zoom logistics. And then we have our subject matter experts, Esmeralda Aguilera and Darlene Torres. And so with that, I'll go ahead and hand things over to them to get us started with today's session. Thank you.
And Berenice, just to confirm, will there be a poll in the beginning or no?
It looks like we're not able to access the poll right now, so we'll see if we can get it up by the end of the meeting.
No problem. All right, great. Next slide. Perfect. All right. So welcome, everyone. It's exciting to see everyone. This, like Berenice said, it looks beautiful outside. Today, we're focusing on ethical decision-making and enhanced care management. Something that I believe that we all experience in our day-to-day work. Ethics in ECM is not just a theory or a policy topic. It affects how we interact with our members, how we document services, how we set boundaries, and how we decide what is within our role or really what isn't in our role. Many of the families we work with are experiencing high levels of complex kind of acuity, and including, system involvement families, behavioral health needs, housing instability, medical needs. And when these situations are complex and urgent, it's really easy for us to drift outside the scope of work unintentionally or even without realizing it. So this training is really going to help us pause, think critically, and use ECM policy and ethical principles to guide our decisions. And I think that as case managers, it's also important that we play a role in modeling ethical practices for our peers. Next slide, please. All right. So our hope is by the end of this session, you should feel confident in these 5 areas. All right. First, we're going to apply core ethical principles to ECM work. Secondly, we're going to recognize common ethical risks we see in ECM, especially when we're working with high acuity members. Third, using ECM policies as a guide for decision making, particularly around scope and boundaries. Fourth, documenting services in a way that demonstrates both ethical and medical necessity. And then finally, modeling ethical practices to your clients and your teams. Next slide, please. All right. So we had a poll, not working right now, but I just definitely, to engage everyone, I'd love it if someone can share with us. I think I'm going to just skip on to the next slide. So go ahead and stay there, Memo. But I wanted to see if anyone would like to share one word in the chat describing what comes to mind when you hear ethical decision making in ECM. So there's no wrong answers here, but I'd really like to see what your thought process is. So again, if you could please in the chat write one word describing what comes to mind when you hear ethical decision making in ECM. Billing. Thank you, Gail. I'll give you all at least a minute to kind of boundaries. Great, Jocelyn. Anyone else want to share what they think of honesty? Perfect. Thank you, Margarita. Respect and compliance. Yes, Daniela. Objectives, respect, honesty. Great, great. Thank you, everyone, for kind of sharing with us. Wanting everyone to recognize that none of these, all of these are really tied to ethics. All right, perfect. So, what are ethics? I think that it's great that we kind of talked about it. We're hearing respect, objective, impartiality. Everyone is doing a great job of kind of sharing their one word. But we hear ethics, and sometimes we go to the academia kind of theory of what ethics is. And here, what we're trying to do is define it in a way that is actual and practical. Here, you'll see compassion. Thank you, Mark. You'll see some of the definitions from the Collins English Dictionary. And again, reading it, you don't really get the full impact of what it means as a case manager. But so again, this is kind of going to be that support, that practical, hands-on approach to what ethics is. And at the core, the principles that guide us and how we treat people and how we make decisions in our professional role is really what ethics comes down to. And the decisions we show in small moments are so valuable. So how we respond when a member refuses services is important. How much we support and provide versus helping someone build independence is key. How we communicate with families who may not trust the system is very important. How we allow them to be seen. And then also the way that we document situations in a way that feels respectful and objective. Ethics helps us pause and think about the impact of our actions, not just our intentions. Even when we want to help, ethics reminds us that, is this within my scope or my role? Does this respect the member's choice? Is this supporting long-term independence or creating dependency, which is something sometimes people, unintentionally do. So throughout this training, we'll focus on ethics to help make thoughtful professional decisions in complex situations, which happens frequently, as we all know, in ECM. Next slide.
Thank you, Darlene. Sorry, I think it would be great if I unmuted myself. All right, so I do want to go into a little bit about ethics and as our foundations for ECM services. So when we think about ethics, we don't want to separate that from ECM or case management in general. So you'll hear our conversations go about ethics, professionalism, and so forth. I really want to emphasize that this is a model that is part of case management in general. There is a lot of bodies out there, and at the end, you'll all see the resources that you can access where it really kind of touches on case management, ethics, similar to other professions that we have, because you are all professionals and you are all working within a discipline that follows guidelines, ethics, professionalism. They actually are the building ground for ECM and how we design the work that we're doing. One of the most important principles is members' choice and self-determination. So ECM services, as everyone knows, are voluntary, which means members and caregivers always have the right to make decisions about their care, even if those decisions are different from what we might recommend or what we might think are in their best interest. Our role is always going to be to support informed decision making and not pressure or try to control what those outcomes are going to be. So this is a crucial one when we're talking about ethics. Another key part of ethical ECM practice is providing a person-centered and strength-based care coordination. As you all know, one of the 7 core services for ECM services is really providing a service that it is person-centered, whole person approach. And it's also strength based. So this is key to also being part of our ethics that we focus on. We're focusing on their goals, their strengths, taking into consideration their culture, their values, their lived experiences, not just the problems that they're facing. So really looking at it through that strength based perspective. We also have to be very careful not to coerce, overreach, or create dependency. This is a very tricky one as we're doing case management and kind of what our ethics are and our rules and the boundaries. One of the things I always say is in case management, we are really touching every single part of a person's life. We're not just really focusing on one discipline. Therapists, for example, focus on therapy and really work on that part. You know, we have medical providers that really focus on their scope of practice, which is the medical side. Case managers, you are involved in very different aspects of a person's life, medical, behavioral health, um, family. You become that one strong foundation for them. But that is a very gray area where can really individuals and families can really build dependency on us. So we have to be very careful. And you as a professional are the one that has to really hold that boundary and really help support in a way we're also modeling that for our families. Ethical ECM practice also means staying within our scope. Like I mentioned, we have to understand what our scope is. ECM is non-clinical care service coordination. So our role is to connect, coordinate, and advocate, not to replace our therapists, not to replace medical providers, and not to replace caregivers. And finally, ethics means knowing when to seek supervision and consultation. We are working with very complex families. We're working with very complex cases. Ethical decision making is rarely something we do alone. Reaching out for guidance is actually a really good sign of very strong professionalism within your practice. So these are core foundations when you're working with ECM and the ethics that you should be considering. Next slide. So I'm going to get a little bit into the nitty and gritty. So let's talk about ethical principles behind ECM. It is important to understand that those principles are not just philosophical ideas. They're built directly into the ECM policy. So now we're referring our ECM policy that is our guides of how we're delivering the services. So DHCS ECM policy guideline outlines several requirements that define how our services need to be delivered. So ECM services, like I mentioned, are voluntary and member driven. That means members always have a choice to engage or decline the services at any point. And our role is to support, not pressure, and for participation. So that's an art, something that we will be working on. Services must also be person-centered, culturally responsive, meaning we are recognizing the members' lived experiences, their culture, their strengths, and when coordinating the care. We're always thinking about this when we're talking to our members. Another key requirement is that ECM services must be non-clinical and non-duplicative, like I mentioned. Our role is care coordination, not clinical treatment. We work alongside other providers, other professionals, instead of replacing them. And then ECM services need to be coordinated within a broader care team. Again, I'm referencing back those ECM policies, the guides, the care service, the core services for ECM. We may be including medical providers, behavioral health providers, we're including schools, child welfare system, community organizations. At the end of the day, we are that main contact for our providers, for our families, for everyone to really know what's happening and what kind of care coordination is needed for our families. And then finally, we must align with documenting medical necessity, meaning that we should clearly connect the members' needs, goals, and treatment plan. I'll touch a little bit more about the importance of documentation as we start kind of working on creating those boundaries and supports for our families. So here, I just kind of want to, see two concepts that we watch and we want to kind of be considering when we're doing ECM: boundary drifting and scope violations. Boundary drifting happens when we slowly start doing more and more for our members beyond our role. often because we just want to help. We see our families, we see the need, we are entrenched in helping them and supporting them. Sometimes that can create our natural need to really want to help and go beyond that. So that's something where we have to be very considerate about. Um, and if that continues to happen, if you continue kind of going beyond your scope and beyond what is within your professional boundaries, this can really lead to scope violation. And where we are providing services that ECM was never intended to provide. This is when we're going beyond those care plan goals. This is when we are talking about our goal is to help support a family connect with, I don't know, applying for Social Security services or applying for a specific benefit. And then we start drifting off another route that really has nothing to do, just such as providing legal support or trying to advocate on something that is really not within our scope as case managers. So, recognizing these early on really helps protect our members, your colleagues, the staff, and as well as the integrity of your ECM program within your organizations. Okay, next slide. All right, so talked about ethics. Now here I want to talk about our professionalism. They go hand in hand. Professionalism is another key part of our ethical ECM practice, case management practice that we have. So at its core, professionalism means maintaining the standards and responsibilities expected within our role when situations are challenging. So in ECM, professionalism will show up in several ways. It means staying within your scope of practice. You'll hear me say this throughout this training, staying within your scope of practice. Even when members are asking for help that goes beyond your role. This is tricky. I will acknowledge this, and there's a lot of gray areas. But really understanding your role, your responsibility, and your scope is going to be crucial to make sure that you stay within ethics and your professionalism. It means maintaining appropriate boundaries with members and families while still being supportive and compassionate. You can be yourself, you can be compassionate, you can support in every way, but you have to always maintain that appropriate boundaries. Professionalism also shows up in how we communicate, how we document and represent the ECM program for our organizations when working with other providers and community partners as well. Another important part of our professionalism is that consistency. Members and partner agencies should be able to trust that ECM members, case managers, staff will respond in a reliable and respectful way. Consistency. Keep in mind, sometimes our families don't have that consistent person. Sometimes our families don't have that support that we need. We always have to make sure that we become that consistency for them, that one reliable source for them to be able to help coordinate their care. Professionalism does not mean being distant or cold. So again, just because you're setting boundaries, just because you are being very clear with what is your role and your scope, that does not mean you have to be distant, does not mean you have to be cold. You can do this in a very compassionate way where you are very respectful to your families and you are still meeting their needs. You can still be warm, empathetic, and very supportive within this role. So what does professionalism, what does that mean? We are intentional and thoughtful about how we provide services, that our work remains ethical, sustainable, and aligns with our ECM role and responsibilities. Okay, next slide. Okay, so professional boundaries in ECM. Talked about professionalism, so now let's talk a little bit about what those look like within our ECM roles and how we're applying them. So this is a very challenging one. I will kind of call it out. In ECM, we often work with families who are experiencing significant stress, housing instability, medical needs, behavioral health challenges, or system involvements. Because of this, it is very natural for us case managers to want to step in and do more. These are those families that come in and are in crisis. I don't know how many of you have had housing instabilities where you have a family that will come in and be like, I'm getting evicted in 3 days. I need help. I don't have nowhere to go. I'm going to stay and, be in my car. I think these are things to really consider because this is where your professional boundaries come in. This is things that you really want to consider about what is within your scope. What can you do to support these families? Your boundaries will really help ensure that our relationships with our members remain professional, supportive, and focused on member goals. So, boundaries help us maintain, like I said, appropriate case manager member relationships. Our role is to support, coordinate, and advocate, not to become the family member, their personal friend, or any other support system that is not within your case management role. They also help prevent dependency in dual relationships, where a member may begin to rely on the case manager in ways that go beyond their services. Boundaries also protect staff, members, and the ECM program, like I mentioned earlier. When roles become unclear, it can create confusion about expectations and responsibilities. And then another key point that ECM services are designed to be goal-driven and time-limited, meaning the goal is always to help members strengthen their support system and connect them over time. Going back to our core services for ECM, we're accessing their natural support system. We are accessing resources that they're eligible, but the goal of it is to really support them to understand how to navigate those systems. And from the minute you enroll them in services, you start having that communication with them that this is a time limited service. You are not meant to be there for years and years on end. So I think it's a really important thing to just kind of highlight within your boundaries that you are going to be creating as you start working with your families. And then one of the biggest misconceptions is that boundaries means that we are careless or we don't care. We don't want to support them because we're setting these boundaries. But in reality, the boundaries are a form of ethical care. They help ensure that the support we provide is structured, sustainable, and truly will benefit the members in the long run. We are there to be their guide and to support and to try to provide training on how to navigate a very complex system. Okay, next slide. Okay, so core ethical principles in ECM. So these are what guides case management practice, and they apply directly to the ECM work that we're doing. So you don't have to memorize these terms. You know, said I'm putting them out here just to know these are core ECM case management general terms and core principles. But I want you to understand the idea behind these and helps guide decisions when situations become a little bit complicated, because we will have very complicated. The first one is autonomy. Autonomy means respecting the members' and caregivers' rights to make decisions about their own care. Even when we believe a different choice might be better, or the role is to provide information, our role is to provide that information and not to control that outcome. Autonomy is a very hard one for a lot of us. A lot of us in case management will get some countertransference. This is where we really have to consider where our role, are we getting triggered by someone's making a decision that we feel strongly they should not be making. This is a time of reflection. We have to really consider, are we providing autonomy? Are we respecting what they're saying, even if we don't agree with it? The next one basically means we're acting in the best interest of our members. What is that? In ECM, we often means helping members connect to services, advocating for access to care, and then helping remove barriers that might prevent them from reaching those goals. A simple barrier is transportation. One of those things is that we're acting in the best interest of them. We want to provide transportation. We're removing a barrier for them to reach those goals. They can get a little bit more complicated, but the gist of it is that we really are acting in what is best for them, but providing the information to them to be able to make those educated decisions. Our next principle is the maleficence, avoiding harm and dependency. This one has a lot of difficulty sometimes. So harm doesn't always mean physical harm. It can also mean creating dependency or stepping into roles that should belong to other people or other providers or other systems. This is the part where we really want to consider, are we creating codependency for our members on us? What is it that we're doing that might be harming them unintentionally? And then the fourth principle, justice, which focuses on equitable access to care. Many members experience barriers related to poverty, language, access, transportation, or systems involvement. Our role is to help ensure that they have access services in a fair way, that they're able to access everything that they're needing in a very culturally sensitive way as well. And then finally, our professional integrity means practicing within our scope, training, and role expectations. This means recognizing what ECM is designed to do, and also recognizing when something should be addressed by another provider or other service. So professional integrity also means if your agency, you as a case manager, you recognize that maybe you are not the best fit to supporting a specific family need, or even working with a specific family or a member or someone that you've been doing supporting with, recognizing that maybe a referral out to another ECM provider might be the best in their best interest. Seeing if another case manager might be in the best interest of supporting that family. Just really having that awareness is one of the core ethical principles that we should be carrying as professionals within case management. So one helpful question that you can ask yourself when facing these situations is, which ethical principle should guide this decision? So when you're being asked, when you have a dilemma, when you're trying to figure out what is the best thing, really kind of look at these principles and ask yourself that question. This question can really help clarify the next steps in your decision. Next one. Okay, so common ECM boundary risk areas. So there are several situations where boundaries commonly become a little blurred in ECM, as you all might know, a lot of gray areas in case management. Examples include providing frequent rights, providing personal financial support, being available outside of your work hours, and becoming the primary emotional support for your member and your family, or unintentionally providing therapy-like support. If you ever feel you are the only support for the family has, that's usually a sign that you need to pause and reassess the situation. One role is to connect members to systems of support, not become the support system ourselves. So these are just kind of common examples that really kind of blur the area, because providing frequent rights, that's a very broad statement. I just kind of put it out there. What is the appropriate amount of rights? It's going to be very dependent on your family. And then I will always say, one of the things you always want to go and look back at is, what are your care plan goals? What is the goal? What are you trying to support those family with? If the goal is, I'm just going to throw an example because right frequency and financial systems can get a little blurry when it comes to certain things, but let's stick to the right one. Example for rights. If your care plan goals are to support a family with health literacy, that means you are going with them to medical appointments. Are you providing that right to the medical appointments? Are you the one that is setting up the ride for them to medical appointments? Are you the one that is going to the medical appointments, sitting in those medical appointments with them, helping them with the health literacy? Like, are you the main person to do all that stuff? I will challenge that and ask you, have you tried the Alliance transportation? Have you tried training your members and supports on how to set up their transportation with the Alliance? That could be as simple as you go to their house or wherever they're going to be picked up. You go through the steps of how they would physically do the transportation request for the Alliance. You wait for the transportation to get there. You kind of help them support through the steps. They're going to call you. They're going to text you when your ride's here. You follow them to their appointment. You do your part for the health literacy with the specialist. And then after that, you allow them to be the ones to take the steps to call the transportation, to send the text message, to wait for that ride. Just really understand your members and what those needs are, but keep in mind, you're not the one going, picking them up, taking them to the appointment. It's a lot of extra steps, but those extra steps do go a long way. But remember, your goal was to get them health literacy. Now you have a member that's asking you for a ride to the DMV, or you have a member that's asking you for a ride to, hey, take me go grocery shopping. I don't have any groceries. Like, those are moments where you got to really consider and think about, is this ride appropriate? Am I overstepping? Am I providing a little bit more that's outside of my scope and those care plan goals that we are providing for these members? So just a couple ideas there. And then personal financial support. Housing instability. We have families that will let us know they're being evicted. It is Wednesday. They're getting evicted from their rental unit or the homeless shelter or somewhere on Friday afternoon at 5 o'clock. They have kids, they have families. What do you do? We have no resources, we have anything. And then you want to help and support, and then you physically will go and pay for a hotel for the weekend just to get you enough time to be able to support them on Monday. That is a huge blur boundary risk that you're doing because now you're using your personal finances to support a family. Um, it is comes from a good place. It comes, but this is something that you really need to be considered and really think about as you are working with your families and these boundary risks. Because once you start doing that, there's going to be other times when this happens. And this is where we get strategic and really kind of start looking into the community supports that we can offer families. Next slide. All right, so kind of still touching on staying within our ECM scope of practice. So let's talk a little bit about why this is very important in the practice. So ECM case managers, we play a crucial role in supporting members, but it is important to remember that ECM is a care coordination service, not a clinical treatment service. Our role is to coordinate. That means helping them navigate the system, connecting them to providers, making sure different parts of their care team are communicating effectively. What we do not do is provide clinical treatment like therapy or any medical care. We do not provide advice on treatment. When a member tells you, my medication is making me sick, when they tell you this doesn't, even if you happen to know a specific medication, even if you happen to know side effects, even if you were there at the appointment with the doctor and you have a pretty good understanding of how that works, you do not give advice of it. You always redirect back to the medical providers and the professionals of what it is, unless you are RNs and have that medical licensure. But in the broader case management, we do not do that level of support. We are non-clinical. We also support engagement, which means helping members stay connected to services that are part of their care plan. We do not replace the role of our providers, our caregivers, or other professionals involved in their members. This is really tricky when we're working with multiple systems, child welfare, our probation, anybody that's helping support the families. We got to really make sure where our role is and how we are supporting those roles. Another important part of ECM is advocating with the members instead of them. We want to support them. We want to teach them how to advocate for themselves. We want to kind of role model that. But our goal is to help them build that confidence and those skills to speak up for themselves and their needs rather than trying to solve the problems on their behalf. And then ECM focuses on building skills and connections. The goal is not to become their members' long-term support, but to help them strengthen the systems around them so they can maintain it over time once you're no longer there to support them. So kind of going back, the two concepts that often happen gradually within the ECM work. Sometimes we care deeply about helping our families. We can experience the boundary drift, like I mentioned earlier, where we slowly start doing more and more outside of our role. If that continues, like I said, it becomes a scope violation, where services move outside our scope of ECM and it's designed to provide. So recognizing these early really helps us protect our members, our staff, and the integrity of our program, like I mentioned earlier. Okay, next slide. So even when we understand the ethical principles, so I just kind of gave you guys a little overview of ethical principles, the scope of practice, there are still situations where the right decision isn't immediately clear to us. That's where a structured decision-making approach can be very helpful. So when you are in an encounter with an ethical dilemma, the helpful approach is to slow down and ask a few questions to yourself. Is this within my ECM scope? Does this support the member's choice? Our role is to support informed decision-making, even if the member's choice is different from what we might recommend. Is this medically necessary and is it goal aligned? Everything we do in ECM needs to come back to what we are documenting and their needs, their goals, and their care coordination. Your care plan goals, what you discuss as a team, is really what you are going to be your guiding source for what services you're going to be providing for them. The other one is this duplicative of another provider's role. ECM works best when we do more collaborative work. We're part of a multidisciplinary team with other providers. We are not there to replace them. And then, have I consulted with supervision? This is a big one. Ethical decision making is very complex. There's a lot of gray areas. It is not something that you need to figure out on your own. Consultation is actually a good sign of strong professional practice. So whenever in doubt, reach out to your clinical consultation, your supervisors, anyone you have in the organization. That really will help. So these questions can really act as a quick internal checklist whenever a situation feels unclear and uncomfortable. So next slide. Thank you. Okay, so here I want to just give you guys a little walkthrough through a situation that many ECM case managers might encounter. So imagine a situation where a caregiver declines a service that the care team believes would really benefit a child. I'm saying an 8-year-old child, let's say. This could be something like behavioral health services, developmental services, or another supportive program. It can be challenging because the case manager, we often see the potential benefit and we want the families to access those resources. We know that if they get connected to SARC services, for example, regional center services for their developmental needs, it opens the door to a lot of other resources, a lot of other supports to the family. But in ECM services, like I said, we're voluntary and we're member driven. So that means caregivers have the right to decide whether they want to participate in the services or not. So our role really is going to be here is, in this example, the questions you're asking is this within our ECM scope? Going back to it, coordinating of care and providing information, we are not going to be forcing participation. Next, we are respecting voluntary participation. If we disagree with the decision, the caregiver still has the right to decline those services. What we do is provide education and information about the services, explain the potential benefits, and answer questions without pressure or coercion. So this is a big one. A lot of times it is providing that education to the families. It is about really educating them about the benefits of the services and really kind of having those conversations with the families of why is it that they're declining? Are they overwhelmed? Because sometimes we're providing way too many services at the same time that managing all that becomes a burden and becomes very difficult. Try to really work with the families and making sure that they are informed of all the services that are being provided for them to make an educated decision about what is in their best interest. It is also important that you document informed refusal. That means clearly noting the services that were discussed, what you provided, what information was provided, and that the caregiver still decided that they were not going to accept the services or they declined it at this moment. Clear documentation is going to be crucial. And finally, ECM should never involve punitive discharges or coercion. Declining services does not mean a member should automatically lose access or support. There are situations where sometimes it can become a situation of, well, if you decline this service, you will not get, another service, or kind of using that as a way to try to engage them in services. And then you discharge them, and then at that point you say, well, now you can't call me. Now you won't be able to get any supports for them. That is not ethical. That is not a way to do the service. You really want to make sure that you really educate them on what is available to them. The goal is really to maintain trust and continue working with the families and be available. So when they are ready, when they do want that service, they can come back. Okay, next slide. Okay, so I am going to touch a little bit on documentation because I mentioned what's one of our ethical practices and things that we really have to be mindful when we document. So documentation is one of the important parts of ECM practice. It's not just paperwork. Um, it's how we show the work that we're doing and how we protect both the members and ourselves and the programs. So good ECM documentation should always reflect the member's voice and preferences. That means that the note should provide what the members are saying, what they're sharing, what their priorities are, how they are involved in decisions, and the care that they provide, that we provide for them. Documentation should also clearly link the members' needs, goals, and interventions being provided. In ECM, our notes should demonstrate how the services connects to the members' plan and coordination. Again, this is kind of going back to when we create those care plans, we are documenting progress, we are documenting interventions, and we are documenting everything that we've been doing with our families. And then the key point here in documentation, the medical necessity. Even though ECM is not clinical service, we must still support the members' documented needs and goals. We as case managers are identifying what we call the social determinants of health. We are identifying the Z codes. Everyone will kind of hear what these are, but we are determining that based on what we are identifying as the need. That is our medical necessity, and we must support that SDOH need and goals that are being provided. And the other thing is that our notes are really going to be reflective of why we're even involved. Why are we even talking to the member? Why are we even providing a service? What is it that triggered us to be there as that support system? So our documentation is really going to really support that. It also important with our documentation is that we remain very objective and non-judgmental. We want to describe situations as factual without labeling or making assumptions about our family members. Your documentation is belongs to your families, belongs to your members, belongs to the people you're individual. So really know that they actually have a right to see your charts. They have a right to see your notes. And you have to write your notes in a way that if they were to read it, does this accurately note what you are providing, the services you are providing for them? Is this accurate to, if they read it, they will agree to it. They will say, yes, you did this, you did that. Yes, this is the progress. Like you really have to be mindful of what you are documenting. And all of our notes as case managers can also get subpoenaed. So this is another one. If a judge were to be reading your notes, this is my rule of thumb. If a judge would be in a courthouse and they are reading your notes out loud in front of lawyers, in front of families, in front of everyone in a case, is this something that you will be proud of? Is this something that you can support if questions get asked? So just keep that in mind. Your notes are your legal documentation. And then your notes also tell the story of the members. They tell the story of how you're working with them, and it's a continuation of care. If you were to have your notes transferred over to multiple providers and everyone's reading your notes, they'll know what's happening with the families. They'll know what to support and where they can come in and come out, and where you're stepping in and ensure that there's no duplication. So final point here is that I really, really want you all to hear, and I'm sure everyone has heard this before. If it's not documented clearly, it did not occur. It did not happen. So if it's not in writing, it never happened. So you must really demonstrate the work we've done when we're working with our families and decisions that were made, and really stand by how the services are really beneficial to our members. Okay, next slide. Okay, just a couple of documentation practices to avoid that could create risks. So these include judgmental language. This is a common one we sometimes see being used is the non-compliant or difficult family. That is a very judgmental language that is sometimes used within documentation. It sounds blaming, and it does not provide a meaningful information of what's actually happening. So instead, you might want to describe the situation. Again, we're talking about objectively and factually. An example would be documenting that the member declined services or expressed concerns clearly, and the information was provided to them. And then you're respecting the situation. So you want to really kind of touch on the why. Why is it that they are not following through or not going with the treatment plan that's being offered to them? Clinical language and assessment is another one. ECM is non-clinical, like I mentioned before, care coordination services. So case managers should not be documenting diagnosis, a medical diagnosis, or a mental health diagnosis. When I say diagnosis, I'm just saying we are identifying SDOH needs, because in the clinical world, they will say diagnosis. So when you're charting, but we are documenting social determinants of health. That's the only type of diagnosis that you would be doing as a case manager. Clinical assessments. These are not screening tools. We have PHQ-9s, we have the ASQ suicide risk assessments, we have the GAT-7s. Like, there's a variety of screening tools that case managers can do. Those are screening tools. Clinical assessments are your full psychosocial assessments that are created to find a mental health diagnosis. Those are clinical assessments that are done by medical providers. So just being very mindful of the difference between a clinical assessment versus a screening tool. And then treatment interpretations. If a medical provider provides a diagnosis or provides some kind of treatment or anything, you can really support the family's understanding what has been given to them by the providers, but you do not interpret those treatments in a way that you are providing advice. So very careful about what it is that you are explaining to families. And then just make sure that you are doing what falls within your scope as a non-licensed, and leave the licensed providers to really explain those things to the families. Copy and pasting progress notes. This is another common issue, and we're all guilty. We're busy, we're trying to document, there's templates out there. We are very helpful with templates, but we also have to be very mindful. Proofread your notes before you sign them off and make them a legal document. Notes should always be reflective of the specific interactions and the progress that the members are making. I will say repetitive notes that read exactly the same visit after visit after visit raise concerns during audits and may suggest that services are not being individualized. So you do not want to make sure that your notes are not reading exactly the same. Follow templates, how use them as guides, but please go back and edit them to be appropriate for what was done in those encounters, for those visits. ECM, and then another one is writing your goals without your members' input. You create the goals for them, you didn't ask them, you just imposed what is it that you felt was in their best interest, and then you went with that. You have to have their input. And it has to be a very collaborative work that you do with the families and your members. And then finally, failing to document refusals or barriers can create gaps in the story. Remember, your notes are your story. You're telling their story. You're telling us what is it that you're working on with them. So not documenting any refusals or barriers can really impact that. If a service was offered but declined and the barriers or prevented follow through, that information should be clearly documented. We need to know what happens if someone, for continuation of care, what is it that you've been working on? So the goal for ethical documentation is to ensure that notes are accurate, respectful, and clearly tied to the coordination and the work that you're doing as ECM providers. Okay. And then just kind of touching more on our ethical language and ECM notes. So like I mentioned earlier, our language matters. What we say, how we say it really has an impact, especially with our families. The way we describe situations in our notes can affect how members are perceived by other providers, auditors, and even future care teams. I want to challenge all of you to really think about notes that you might have read from another provider. Sometimes we will read mental health notes as case managers with the coordination of care. We might read a note from a therapist, from a medical provider. And think about it. The way that note was read, did that change your perception? When you read notes, when you do chart reviews, when you do anything, before you've even met the families, Do you think that affects your perception? Just stop and think about, one of those notes or anything. Please add in the chat if there's any situations where you have where that kind of, and then you meet the family and then you're like, wait, that's not the case. Like, that's kind of tells you the language, the notes that other people write really do impact the way people will see these families. And especially if you're transferring and someone else is going to be working with, and we have to be very mindful of that language. Um, and it is very easy to unintentionally, I'm not saying anyone that documents does it on purpose, but it really does create assumptions sometimes. It labels rather than actually supporting and helping them. So for example, writing that a parent is resistant to services can really come across as judgmental and doesn't really explain the situation. How many times have you read a note from someone else that says that the parent for a child that you're serving, and it says that the parents refuse services, the parents are uncompliant, they're resistant to it. So instead of an ethical documentation, focus on what the member and the caregiver communicated and what occurred. So again, we're talking about what did occur. So here in the second statement is stronger because it provides the context and factual information. It explains that the parent had concerns related to prior systems and chose to decline the services at this time. A lot of our families don't trust the system. A lot of our families don't have the confidence that someone's going to help them. So a lot of times they're just like, why bother? So this is exactly why, because sometimes, they just need a little bit of support. But when you document, you have to respect if they decline it, but you're also documenting the facts and the context, not just the resistant to services. So this type of language really helps maintain dignity and respect for the families while also giving care teams a clearer understanding of the situations. It also protects the ECM program because documentation that is objective, descriptive, and non-judgmental is much more feasible, especially doing audits and reviews. It's more, you can defend it, you can really kind of support what you're doing. And helpful reminder when you're writing your notes is to always ask yourself, am I documenting what I observed and what the member said, or am I documenting my interpretation? Ethical language focuses on facts, context, and the member's voice. So another example that sometimes might happen is you are meeting with the family, there's substance use disorder, and when they come in to see you, you have your suspicions that they might be under the influence of something. Do you have proof? Do you know that's what it is? You have to be very careful of the language that you use when you are documenting something like that. Factual information is you could document the facts. Slur speech, if there was any smell that you had, any kind of you're documenting your observation, not your assumption that they were under the influence of something. So just kind of being very clear when you're documenting these. And this is the ethical language that we want to really kind of focus as when we're talking. Next slide. All right, ethics in ECM practices also require cultural humility. It is very important that we kind of look at this and the equity and kind of how we're practicing this. So many of our members we work with have experienced significant systemic barriers. These might mean including poverty, language barriers, immigration, stress, housing instability, and any past experiences that they might be with healthcare, social services. Let's talk about the political climate right now. There's a lot of stress out in the community. So there's a lot of barriers that are happening for some of our members. So cultural humility really means recognizing that every member and family brings their own experiences, their own values, and their own perspectives. And we approach those experiences with openness and respect. Part of ethical ECM practice is also acknowledging the impact of trauma and system involvement. Some families may be hesitant to engage in services because of previous experiences where systems felt controlling or harmful. Understanding that context helps us respond with empathy rather than judgment. So this is something that we really need to consider as case managers as we are approaching. I'll talk a little bit more about this, but language access. is a key equitable issue. Members should be able to communicate in the language that they feel most comfortable using, which is why using qualified interpreters and clear communication is so important. Another important concept is avoiding pathologizing, poverty and system mistrust. So, for example, missing an appointment or declining services may be connected to barriers like transportation, work schedules, or previous system experiences rather than lack of motivation. So, we really got to avoid that. And in ECM, equity is not just the best practice, it is an ethical obligation. Our role is to help ensure that members can have access to services and supports they need in a way that respects their cultural background, their ethnicity, and their lived experiences. So this is something that we really need to really think about as we are working with our families. So as I mentioned, I did want to touch on the communication effectively, because this is crucial. This is part of the work that we do, and this is one of our strengths that we have as case managers, because we do a lot of communication care coordination within ECM. And this is also one of our ethical practices that we really need to be considering, especially when working with members who have limited English proficiency. We see this a lot where we have members who are not able to read, are not able to communicate. They can't maybe read or write in their first language. So really understanding that now they are living in a place where everything is in English. It's a language they don't understand, and now you're giving them written material. So to ensure members understand the information being shared with them is overall good practice. It is also compliance. I will also go back to our compliance and policies because we want to be compliant, and equity is a requirement within healthcare and the coordination of services that we are providing for them. So whenever possible, we should use a qualified medical interpreter rather than relying on family members, friends, and children to interpret. Qualified interpreters help ensure that information is being shared in an accurate and complete, which protects both the member and the provider. You are documenting if you're using interpreters. So make sure that if you are having a system with that, you have that documented. When speaking through an interpreter, it is helpful to use clear, plain language, avoid acronyms, jargon, any technical terms that might be difficult for the translator to understand. Another key point is who you direct your communication to. Even though an interpreter is present, you should continue to speak directly to the member and maintain eye contact with them, not the interpreter. This helps maintain respect and connection with the member. So you have an interpreter, you see this a lot, the urge to speak to the interpreter and then focus on it can get very impersonal. So really just kind of being mindful of that when you're communicating with interpreters. And then pay attention to verbal and nonverbal cues as well. These can help assess whether the member is comfortable in understanding the conversation. Sometimes you'll have individuals that will just agree with everything, will nod in it, but really you want to really understand, read those cues, understand if they really understand what's being told to them and being said. Are they able to give you that information back? So really kind of use that verbal and nonverbal cues. And then finally, remember to pause frequently. So the interpreter has time to accurately translate the information. And so members has an opportunity to speak, ask questions, or clarify for anything that they might need. Sometimes we just do what I'm doing right now. We talk and talk and then provide a lot of information. And it is always important to just pause and then really understand, do they understand? Do they have questions? Give them that opportunity to do that. So the goal is to ensure that they feel heard, respected, and fully informed when making decisions for their care. Okay, next slide. Okay, so let's talk a little bit about your roles as your lead case managers, which is incredibly important when it comes to our ethical practice. So you are the leads. You're not just managing the cases. You're helping set the tone for how ECM services are being delivered across your teams, across the organization and across the community. You are the representative ECM provider for your organization and for the county in general and your members. One of the key responsibilities is that you are modeling. You are the model for ethics and then your compliant practice. You are for your teams, often who watches how things are being handled, difficult situations, how you document, how you set those boundaries for your members and your partners. You are that role model. Another important role is reinforcing the boundaries in your scope of practices. Sometimes staff may feel pressure to do more for their members than ECM is designed for. If you see a colleague, if you see someone that is kind of in that gray area, say something. As a lead, you are part of the role of helping navigate these situations, work as a collaborative, especially making sure that you are all aligned with the ACM policies. Um, it is also important to play an important role in normalizing and consulting and supervision. Ethical decision making, like I mentioned previously, does not happen in isolation, especially when we have these really complex cases. There's a lot of things that we need to consider. And then creating a culture where you all feel supportive, have a staff, feel comfortable asking questions, and bring concerns forward is a big thing for all case managers and for the leads. Um, and then leads also, I will say, as lead case managers, you also can provide the coaching opportunity, that role modeling for families. A lot of our families don't have that role modeling of boundaries, don't have that role modeling, in their real lives. And sometimes you being that for them is really important. So it shows good role modeling, reinforcing, and again, you become that for these families. And then most important role is identifying ethical and compliance risk early. Identify these things, boundary concerns, any scope issues, any documentation patterns that need support. Addressing these early really protects everyone within the organization, the members, and yourselves as well. Okay, next slide. Okay, so ethical red flags to escalate. So, as case managers, another important part in your role is recognizing the early signs that ethical or compliance issues may be developing. This is for yourself and for colleagues as well. Kind of help each other hold everyone accountable, what needs to be. These are what we often call our ethical red flags. These are our spidey senses, as I call them sometimes. These are like as we start doing the work, we start recognizing these red flags. Identifying them early allows you to support your staff, your colleagues, and before a small issue can turn into a larger problem. So, for example, over involvement. This might look like a staff member, colleague becoming the primary support for the family, taking on responsibilities that belong to other providers, or being consistently available outside of the work expectations. A few trainings back, I kind of touched a little bit about boundaries, and when you're setting up the stage, when you're first meeting with families, it is really important that part of that explanation of your role and responsibility is also down to the logistics. I'm only available Monday through Friday up to 5 o'clock. If I'm not available, these are alternative contact people you can contact. 988 number for emergency. Like that is just kind of part of it. Over involvement means you're becoming available outside those hours, and you are working outside of your expected roles and responsibilities within your work. So it's just really kind of be making sure that you are staying within that. That's sometimes a red flag when you catch yourself or a colleague or someone else doing those things. Another red flag is when yourself or colleagues are providing clinical-like interventions. Remember, ECM is non-clinical. So if staffs are providing counseling, treatment, guidance, interpretation of diagnosis, that really is moving outside of your scope as case managers. You also may hear rescuing language. This is where maybe a colleague or a staff member, or you might even see this in another organization that maybe you might be working with, feels responsible for solving every problem of your client or your members, or believing that you are the only support person for them. Um, while this is usually comes from a place of compassion, it comes from a place of really wanting to support, this can really get very gray and this can build dependency on you. And it can also create burnout, I'm sorry, with the services that are being provided. So burnout usually happens when we are trying to rescue our clients. Remember, we're not rescuing them. We are providing the resources. We're supporting. We're doing care coordination, and we are educating them. So really looking at that rescuing language that you might come across. Even in consultation with other people, if you start hearing this and it really sounds like that, that might be a red flag. I was just really trying to identify it early on. And then inconsistent and vague documentation is another signal to pay attention to. Documentation that doesn't clearly describe the coordination being done can create compliance and risk and may indicate that, maybe yourself or staff or someone else needs a little bit more guidance. And then finally, one red flag that sometimes goes unnoticed is burnout framed as dedication. So this is staff who feel they must constantly go above and beyond, work outside their boundaries, and carry caseloads alone are at risk for burnout. Huge red flag when you yourself or staff member or colleagues or feel very burnt out and you see them doing these things. This is a huge red flag. And then ethical practices can be really affected during these times just because you are on the go, go, go. So recognizing them these early can provide an opportunity for coaching, supervision, and support. And again, we want to all hold ourselves accountable and really support each other because this is our profession and we represent the profession of case management. So really kind of taking this into consideration. Okay, and I'm going to hand it off to Darlene.
Yes, but before I do that, I just want to make sure everyone stands up really quick, gets a stretch in. This is the first time we've gone past an hour, and we thought it was important. I mean, your feedback is also very important. So stand up, take a quick stretch. We're almost at the end of this presentation. This is so important to the work we do. I don't want to forget to honor you all in your space that you're currently in now. So again, just giving us a minute stretch to get us refocused. I can't see everyone, but I'm hoping that that's what you're doing. Stretching those arms, standing up, moving, make some movement. But all right, great. I'm going to get us wrapped up with this presentation. And thank you, Esmeralda, for providing us some very concrete examples of ethics and ECM. These red flags are really the best signal of a red flag is your own comfort. And that's why when I ask you to just stand up right now and feel yourself, feel where you're at, be present. If we're recognizing, you're welcome, Juliana. If you're recognizing that you're feeling uncomfortable, that's a red flag. You have to pause for a moment and ask yourself the questions. Why am I feeling uncomfortable? Was that ask appropriate? Is there some ethical decision making that needs to happen to make us feel connected with ourselves again and take that discomfort away? I think it's always important for us to pause. And if needed, consult before we make a decision and even review policy. I often say that one of the things that Esmeralda and I do regularly is consult because there's all these questions that are asked, and is this us providing support and providing the family or the individual the tools they need, or does it feel like this is unethical? This is us enabling our patients. So just wanted to kind of really make sure that we understand that if we're connecting with ourselves, understanding where we're at and it doesn't feel good, it's probably unethical. And we need to do some follow-up with the consult, pausing, and reviewing privacy. Next slide, please. All right. Very, very nicely done. Diagram here. Here's a quick ethical self-check that case managers can use when they're facing difficult decisions. We wanted to be as concrete as possible, so it's here As a visual, I'm a visual learner. I appreciate having something like this to support that. Sometimes situations with ECM move quickly. There's time frames, there's urgency, there's issues that escalate that if they're not addressed quickly, or if we don't respond right away, then it might be detrimental. So sometimes it's important for us to make sure that we follow this checklist and still pause, because there is the value in making sure that we're connecting and understanding. The first question we should be asking ourselves: is this action legal within ECM scope of practice? ECM is non-clinical care, of course. I want to remind us of that. But the first step is always making sure that the action fits within ECM in its design and scope. Next, is this fair and equitable to everyone involved? So is it fair for me and the rest of the care team? What's being asked of one person as opposed to the others? And again, is it fair? Is it equitable? This also ensures that we're considering the needs of every member in the care team. Again, the caregivers, the providers, and again, the broader team. Third here is, does this align with our ethical standards and professional values? Even when something is technically possible, it should still align with ethical principles. And Esmeralda talked a little bit about autonomy, integrity, and avoiding harm. And those are things that we should, again, make sure that we're aligned with if we're sitting here and taking this moment to pause. Another helpful check is asking yourself, would I feel comfortable explaining this decision to my supervisor or my team? And I like this one because oftentimes it makes sense in my head. And then when I say it out loud, I'm like, oh, wow, okay. Yeah, no, that doesn't feel right. That doesn't feel ethical. It doesn't feel like it's something that I would feel comfortable sharing in a consult. So very important. So if the answer is no, that often is a signal that it's time to make sure you consult. Next slide, please. Thank you. All right. So ethics is a daily practice, just like movement is a daily practice. Self-care is a daily practice. We're in a field currently that burnout is a real thing, and we need to really make sure that we're supporting ourselves and balancing all those expectations. We need to be able to show up every day, able to make every interaction where we're feeling that the individual was seen, but that also that the notes reflect what was happening. Ethical practices requires clarity in the scope, clarity in your the documentation, and then also boundaries, having very clear boundaries, having those mapped out ahead of time with the family or the individual, and then of course integrity. When you have these three elements, ethical practice becomes a part of your daily work. And I think that's really what this diagram is here to hammer out, the fact that every day we have to make sure we're practicing from a place of integrity, boundaries, and clarity. And again, that hopefully will lead us to those ideas of following ethics on a daily basis. Next slide, please. Awesome, thank you. All right, so key takeaways I hope that everyone is able to take from this presentation is that ethics guide everyday ECM decisions, and boundaries protect members, staff, and programs. It's important for us to also make sure that our documentation is aligned and demonstrates our ethical practice and compliance. Again, lead case managers set the tone for ethical practice, and consulting is so key. And I think even if you are a seasoned case manager, it is important to make sure that when needed and regularly that we consult with our partners and our supervisors. And so again, these are all the key points. These are the ways that we wanted to make sure that you're taking this information concretely from the training today. Next slide, please. All right, before we wrap up, I want to take a quick moment for reflection. So We stretched a little bit. I want you to think about everything we discussed today: ethics, boundaries, documentation, scope of practice, and your role as lead case managers. This question is meant to help you translate the training into something more practical. So take a moment and think about one ethical or boundary practice you want to reinforce moving forward. It would be great if you can share that in the notes if possible. I know that we're getting close to time, but I just thought it would be great to kind of, see that what you think you would take on moving forward. And again, there's no single right answer here. The goal is to simply reflect on one takeaway that you will be doing in your daily work. And again, I hope you're comfortable enough to kind of share that. If not, that's okay. But that's really the end of this piece of the training. I don't know if anyone is brave enough to share with us what they're going to take with them. No? Okay. All right. Well, I will pass it over to Berenice and Memo.
Okay, thank you, Darlene. Not sure if you want to say anything about this references and policy resources, or just they're kind of for reference if folks are interested in reading more.
Yeah, that's
Yeah.
really what they're there for, just in case anyone wants more depth in some of the points that we made in our presentation. And I want to thank someone was brave enough, so thank you. A language
Yes.
change in documentation. I use non-compliance a lot. Great, awesome, thank you. Oh gosh, these are great. I'm glad that people are starting
Mhm.
to share them. Gail, thank you. Daniela, thank you. Erin, thank you. This is great. Not being the sole support person. I think that's valuable. We want to make sure that we're surrounded by a team. That notion of it takes a village. It really does. It takes a village to be there for each other and to be able to support true change, better documentation, maintain boundaries. Thank you so much, everyone, for sharing what you'll be taking away that's important to us. Empowering members will roll boundaries. Great. Thank you.
Okay. Well, thank you also, Darlene and Esmeralda, for walking us through today's session and for sharing these examples and really guidance around ethical decision making and ECM practice. We hope that everyone enjoyed today's session and that you've learned something new and that you're able to bring these practical strategies and begin implementing them in your day-to-day work. Before we wrap up, I did want to note that when you log off of this Zoom meeting, you will see a survey pop up in your internet browser. So this survey is to help us get a sense of how helpful today's learning session was for you. So this feedback really helps us understand what's working well and how we can continue shaping these sessions to best support you in your day-to-day work. So again, just thank you all for taking the time to join us today and for sharing your feedback and engaging in the session through the chat. As always, we appreciate your participation and we hope to see you at future sessions. We hope you all have a good rest of your day and that you enjoy your weekend.